If that's not working or it's too high risk because of a curve, I'll dissect behind the stent, crush it, re-enter distally, and stent over it, which tells me it's probably what I should have done in the first place. And it's amazing how beautifully calcium yields when you get behind it, right? You go through the media and then you re-enter, it'll crack like nothing.
So let me invite the next presenter, Dr. Gopalamurugan. And there's one last comment we are having. In the meantime, Dr. Gopi comes over to the, come over.
Yeah, just wanted to share the use of experience of the IVL for the young doctors. Either you prepare the bed good for the IVL, otherwise for the long lesions, if the bed is not prepared, just be careful about the IVL. It's a bulky balloon. Suppose if it's a 20 or 30 millimeters lesion, if you take a IVL to the distal side and you use the IVL, and if it slips beyond and try to pull it, the whole guiding catheter will go, and it's very difficult. So you keep it little less than distal and then keep doing it. And if you keep it proximal, then it will not go distally. So you have to place it very, very carefully or prepare the bed nicely before using the IVL.
Thank you. So for a long time, I used to look at Gopi and wonder whether this is a South Indian film actor. Now when he goes through his presentation,
I didn't realize you called me here to embarrass me.
At the end of the presentation, we'll take a voting count. All right, Gopi, over to you.
I will run out quickly. Thank you, Dr. Mathur, for having me here, and respects to the chair and panelists. I deleted a lot of slides because I think Kirti covered most of whatever I was going to present. So my job is just to talk a little bit on laser, but I'm going to talk a bit of everything actually. So I cut down a lot of cases. So I cut down a lot of slides that talked a bit. So I'll just show images which might be of interest. So let's start with this case. So this is what we thought this patient will have a straightforward young guy, 45, stable angina, and this is his right coronary artery. You can see here the right coronary artery. I've just put a zoomed view there. This is more, it looks like a dissection. It looks more like a honeycombing, perhaps an organized thrombus. There are some beautiful Google OCT images you can look for. But anyway, we thought we'll put a wire and then we'll get some images. So you would have thought this is a straightforward lesion. So I started wiring and took at most 10 minutes to get past this one. Now this is a pilot 50 and it wouldn't go through what I thought was a straightforward non-calcified lesion based on angiography. And you can see here I'm struggling and the guide is backing. Perhaps you could argue we'll take a different guide, but I thought we should be able to get through. This is just another orthogonal view to make sure I haven't missed any interruption in the contrast. So it's not an interrupted vessel. There's something there, it's just not allowing the wire to go through. So I took a balloon backup just to give extra support. And after trying for a bit, I managed to get through. There you go. So my wire has crossed the lesion, and now you thought the job is going to be done. So the wire goes to the distal, and here I take the 2 balloon, and the balloon would not pass at all. So I thought we'll take a smaller balloon. This is a 1x10, a small balloon, and even that would not go past. Now this is the moment you start getting irritated. You want to know what is the mechanism, and I'm a very pro imaging guy. I need eyes there. I want to know what's happening so that I choose the right tool. So if I take an IVUS, I need a 40 megahertz IVUS. A 40 megahertz IVUS with a monorail ain't going to go through. So I want an eagle eye where at the point of resistance, I want to see what's there so that I take the right tool. So I take an eagle eye. And as it goes and hits where it would hit, I took some images. So you can see here, it's all soft plaque. The eagle eye would not go past that lesion. I don't see much calcium. So clearly it's a soft fibrotic lesion. I know I should be able to get through with something less aggressive than rotor or shockwave. So I took a laser. So here we took an ELCA. You can see here, this is a guide liner. I normally take guide liner so that we can be as coaxial as possible and deliver the saline flush as close as possible. So once that is done, start an ELCA. This is a 0.9 at the point of maximum resistance. Decided to laser through. So started with 60-60, which is my standard, and quickly go up to 80-80. And you can see here, very slow lasing to make sure we get as much ablation of tissue. We know it's soft tissue, at least at the point of maximum resistance. Then quickly move to 80-80, which is 80 fluents at 80 frequency with saline flush going through. And the whole thing was laced. And once it was laced, just took a shot, and I knew I'd have made some room. And here, a 2.5 balloon goes in, and after that, it's a piece of cake. Straightforward angioplasty. Take the guideliner all the way in, just to protect your stent as it goes in, and then you put a stent. And I don't want to go through the entire procedure. And the procedure was completed. This one was a wire through, kit not through, where laser really helped. After imaging at the point of maximum resistance, making sure what is the kit that is best suited for this device, for this lesion, and we managed to complete the procedure. This is another coaxial view showing a very pleasing result. And this is an IVUS showing, yes, indeed, it was not calcified at all. Even outside the stent, you can see there is no calcium. It was indeed fibrous tissue, which we managed to ablate with laser, proving that indeed laser was the right technology that was needed for this case. Now, next one. I'm going to show laser, rotor, and litho. Again, this is not uncommon. Sometimes you need all three, but I'm hoping this single case will demonstrate why this case could not have been done without either of these technologies. You just need all three. And I'm going to use imaging, and hopefully you will be convinced. So this is a patient who had critical ischemia, angina class 3 to 4, very tight right coronary artery. And it's been having it for some time, so you know it's not thrombus, it's going to be something hard and calcium. This is another view. You can see here on the RAO, it probably is interrupted at one point, but you couldn't be sure. So this is just a close-up of the LAO and the RAO, a long segment, fairly complicated lesion. Again, I start wiring and start struggling for a bit, and a straightforward wire would not go through our workhorse, so switched quickly to a pilot, and then this is with a balloon backup support, trying to increase my tip load. I managed to cross through. Now the wire is crossed. I'm in the true lumen, and now my balloon would not cross through. So this is a 1/10 balloon. It just would not cross through. I tried desperately ballooning, hoping I'll create a little bit of space so that I can take a quick microcatheter in exchange for a rotor. That was the intention at that point. But even after ballooning, nothing will go through. So this is another wire, a rotor wire, hoping we will just sneak past that the other wire, the workhorse wire, but nothing will go through. So as always one would do, you would have thought you can just wedge it with a microcatheter, take off that wire and quickly exchange with the rotor wire. That was my strategy. So here I wedged my corsair as much as possible to the point of maximum resistance. I've literally screwed it in, decided to take out that wire and now take a rotor wire through. But here, this is where I took a rotor wire, and my rotor wire is coming in, and to my surprise, that wouldn't go through at all. Now you start clenching your bum. Now your rotor wire isn't going through. Is my workhorse wire going to go back because you've taken the wire out? So now the patient starts getting chest pain. You can see the hand going up because I wedged that little micro channel, so it's getting a lot of ischemia, so I need to be quick, but managed to get a pilot 50 back through that. Now we need to think carefully and do something so that the patient doesn't get much more ischemia. So I managed to take out this microcatheter and decided to rotor. Here I didn't take a guide extension because I was sure I was fairly coaxial, and even if I had a little bit of contrast of blood, I wanted more energy because this was really tough. So I took a laser, and this is 60-60, trying to lace through wherever a little bit of bonds can be broken for me to take a microcatheter and a rotor wire. That was the intention. So this is ELCA 8080, did some lasing, and after that I thought there was a little bit of contrast, slightly more dense than what it was initially. So I took a rotowire, and here my rotowire just flies through. I didn't take a microcatheter at all, so I didn't have to exchange. I just took a rotowire and it flies through. So I started with a 1.5 burr and drilled a little bit, and I thought we needed to upsize the burr, and this is a 2 burr, and we took a 2 burr because there was quite a lot of calcium chunk, and ablated as much as possible. So here you go. So the 2 burr went all the way through, so I was happy. So did a quick injection, and here I could see here I've made enough room, but then there's a big chunk of calcium nodule. We have a 2.3 burr, but then I knew the 2.3 burr isn't going to do anything to that. It's just going to go through the normal tissue, and I'm not going to get really ablate. So I decided to have a quick peek into what I'm looking at. This is IVUS, and IVUS proved that I had a big calcium nodule. So at that point, I decided to take lithotripsy. So this is a 3 lithotripsy, and decided to crack that nodule, because what we need to do, having done so much work, is to be absolutely sure we get a good MSA, do whatever it takes to minimize TLR in this patient. So this is a litho, and after the litho, straightforward angioplasty, put some stents. And this is just the final result. This is just a close-up. On the right-hand side, you can see the previous image, and this is a coaxial view, achieving a very pleasing MSA with IVUS. Of course, I'll show the final IVUS, and the IVUS was clearly from calcium to calcium, but then the MSA was very good. We had pushed all the calcium out. There's a little bit of calcium protrusion there, and the MSA was pretty good, and I was pleased at that stage. We put a terminology called rollotripsy. You can name it whatever you want, but that was to spell out rota, which was meant for debulking. Clearly, that was the only technology that I had which could debulk effectively. La for laser, where it's a passage navigator, wire through, kit not through. So laser is indeed the best, and we had that. And tripsy is to just modify the calcium. So rollotripsy, I thought, gentlemen, we should put that term to be used here. So laser angioplasty, my favorite is wire through, but kit not through. The best technology ever, and it's really a big boon in my lab. Of course, thrombus, we get a lot of MIs that come very late, and you have a thrombus for at least 2 centimeters before the lesion. You could just lay strings through rather than try suck out, because usually you're unsuccessful. And of course, for ISR, rather than squashing, cutting, you might as well ablate tissue so there's as little tissue as possible without the 2-layer stents. And with that, I will finish my presentation. And ladies and gentlemen, if anyone is interested in structural valves, please mark your dates, 9, 10, 11, for a TAVR party at Goa. So we'll have everybody interested in valves, and we'll have every single technology in valves. So it'll be a great occasion for everyone. Thank you.
Excellent. So I hope you got a copyright for this rollotripsy.
Sorry?
Did you make a copyright for this term?
No, I just made it
They've
up.
already taken pictures, and it's already on Twitter, you know. All right.
Heavy, nice talk.
So there are 2 schools now.
Yeah, suppose you have a failed CTO wire crossing. If you put laser in the diagonal, would it make the tectonic plate of calcified CTO paralyzed? Number 1. And suppose you are not able to pass the wire, can you put the laser on guide extension? Because I have seen a poster in TCTACV this time. I asked this question to Professor Mehta 3 years back. He just laughed at me. Are you fool? So can you pass the laser without wire in the CTO center?
No, I wouldn't, because you don't know the trajectory against which you're lasing.
On guide extension.
Doesn't matter. The guide extension, you could be in a bend. You don't know the trajectory of the vessel, and I wouldn't lace through, so it should not be done. Of course, it can be done for peripheral vessels. I do peripheral angioplasties where, even if you perforate, you can't do much damage. That's why you do it. But technically, you just don't do it. But in peripheral vessels, I do leave it there, boom, 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 lays, and then it goes
diagonal.
Animated videos are there. You see,
Yeah, there are some
animated
posters.
videos are there where the layman people are sending.
But a lot of people think
Dangerous.
that animation is inside coronary, so please don't do that. So this is not for coronary. So coronaries, unless you have wire, it should not do. That will be my
Dr.
point.
Mehta?
And then coming to the point of calcium, sorry.
Sorry.
Coming to the point of calcium, laser doesn't do anything to the calcium, period. So it just doesn't destroy calcium. It breaks the bond between the calcium and the fibrous tissue. So what it does is loosens up tissues for you to get things through. It is not an alternative for rotablation. So no.
So it's not for all non-crossable calcified lesions.
Non-crossable, what it does do perhaps is just break the little bonds, which it did in my case, for us to allow microcatheter and kit through, but it didn't really ablate the calcium. So rota is not, or laser is not an alternative for lithotripsy or rota. It's just a completely different technology. And that's the whole point of my case, is to show in this day and age, you can't run a quaternary care without every possible kit. And I know it's expensive, but you should not make dosa if you don't have a pan. So it just sucks.
Dr. Mehta, sir.
No, Dr. Hazar, I remember this question that you were asking me. But it is true that it came as a surprise to me, because how do you go forward without the wire? Because you do not know where you are going. And if you go haywire, you will do a damage including perforation. Point is this, that just as we talk about penetrating efficiency, we should also think in the lines of crossing efficiency. You have difficulty in crossing, which I think if you put an extreme form of a deficiency of crossing, then is a chronic total occlusion. And where the, I think three factors which help you to increase the efficiency is: one, the tip, smaller the tip, better is the crossability. Lubricity, polymer has better crossability, and tip low. Now I think in this kind of cases, you should have a low resistance to use a polymer wire, especially those kinds of polymer wire who have a tapered tip and a reasonable tip. So those kinds of things. Now you have a gladius also.
Sure.
So those kinds of things can be helpful. And also, I think, yes, sometimes, though I don't have a very large experience of laser or right, but I do have some. And that I think the laser wire's profile is much bigger than certain microcatheters like Torners. And there is no rule that you can't use Torners in anything else other than the total occlusion. And the Torners 44 and 88, both, depending on tortuosity or requiring penetration, you can use alternatively wherever you want, depending upon the demand of situation. This I am suggesting is an option, Gopal.
Sure. One take it.
So thank you very much. This has been an exciting session, a long one, lot of discussions. We've virtually covered the entire spectrum of tools and armamentarium required for calcium. So thanks to all my experts as well as discussants.